will be speaking with you over the next 10 minutes, hopefully no longer than that, on medical therapy in heart failure. These are my relevant disclosures. So as I mentioned, I've got about 8 to 10 slides, and I'd like to start and end with some key points. 1, what is heart failure at its core? 2, what are the pillars of medical therapy? 3, let's start to consider ejection fraction along a continuum. 4, let us remember that language matters when we're talking about heart failure. And 5, medical therapy is never an or and always an and. Failure is a clinical syndrome. This comes from the new universal definition of heart failure published in the Journal of Cardiac Failure in 2021, where we know that there are signs and symptoms of heart failure that are caused by a structural and or functional cardiac abnormality. But now, importantly, there is an emphasis on the need for corroboration of at least one of the following that represents congestion. That is either elevated natriuretic peptides or objective evidence of cardiogenic, pulmonary, or systemic congestion. So let's remember again that this is a clinical syndrome that we need to keep in mind. And now more than ever, the proof of congestion is necessary. The stages of heart failure, I'm just going to focus on stage B and stage C. Important changes have been made to our nomenclature in the past year, namely stage B heart failure, which was patients without current or prior symptoms or signs of heart failure, but evidence of structural heart disease, of normal cardiac function, or elevated natriuretic peptides or troponin levels is now called pre-heart failure. The focus of today, of course, is our clinical syndrome and actively symptomatic or with of heart failure in stage C. Importantly, we now recognize the need to adapt the nomenclature from our oncology colleagues such that with medical therapy, we hope to allow for patients to enter remission. If patients remain symptomatic despite medical therapy and other interventions, they are considered to be in persistent heart failure. Approach to heart failure. I used to think of it, okay, you have heart failure with reduced ejection fraction, heart failure with preserved ejection fraction being over 50%, and then there's an intermediate or in-between zone between 41 and 49%. And then regardless of the ejection fraction, we can see patients presenting in the acute decompensated state or in the chronic heart failure state. And depending on where they fit into this paradigm, there were different therapies that were applicable. Amazing to see how far we have come over the past 20 plus years. These are all of the positive trials, particularly in heart failure with reduced ejection fraction. And obviously going over each individual trial is beyond the scope of this 10-minute talk, but this is just a really nice overview to see how much evidence we have to support the medical therapy that we use, particularly in those patients with reduced ejection fraction. With beta blockers early on, angiotensin receptor blockers, as well as ACE inhibitors, mineralocorticoid receptor antagonists, more recently the ARNIs with Paradigm, and then SGLT2 inhibitors. So where does that leave us? Let's distill it down and keep it really simple. These are the pillars of medical therapy. It is quadruple therapy with ARNI, beta blockers, mineralocorticoid receptor antagonist or aldosterone antagonists, and SGLT2 inhibitors. I really like this schematic that comes from Greg Fonarow, where we always get asked, which one should I start first? How should I layer these? The point is that we want all 4 of these on board. It is incredibly important for us to emphasize that fact. And what the analogy that he's made, which I think is kind of nice, is if you have a tiger in a cage and you don't want the tiger to get out, you want to be able to bind it from all 4 sides. And so consider this each side of the cage to keep the tiger in. Of course, many other medical therapies that we want to keep in mind. And I apologize, this is a little bit blurry. Again, beyond the scope of our talk today, but outside of the mineralocorticoid receptor antagonists, beta blockers, SGLT2 inhibitors, and the ARNIs, we of course have the loop diuretics for congestion. If there's persistent congestion, there'll be an addition of metolazone or a thiazide. If there are repeated admissions, more recently, we have seen the efficacy of vericiguat. If patients are in sinus rhythm, but with persistent symptoms or repeated hospitalizations, there's consideration of digoxin. If patients are intolerant to ARNIs, the addition of hydralazine and isosorbide dinitrate as per our most recent updated guidelines. And then if they are iron deficient, we should also consider IV iron. If patients are in atrial fibrillation, of course, the addition of anticoagulation must be considered. And then finally, if patients are in sinus rhythm, but with a heart rate over 70 beats per minute, the addition of ivabradine can be considered. My old approach, this is my new approach. And the new approach really is to consider ejection fraction along a continuum, such that we are seeing with recent data, particularly with mineralocorticoid receptor antagonists, angiotensin receptor neprilysin inhibitors or ARNIs, and SGLT2 inhibitors, EF matters less when we're considering medical therapy for the treatment of heart failure. We need to consider ejection fraction along a continuum. With the exception of beta blockers, this is sort of how I think about them along the continuum of ejection fraction. For the low ejection fraction, all four are indicated. And as the ejection fraction increases, and of course we need to tailor it per patient, we need to consider ARNI, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. So we have guideline-directed medical therapy for HFrEF, for mildly reduced ejection fraction, and now for preserved ejection fraction. So to our next point, language matters. We use this word heart failure, and that is not to deny the grave disease that it is and how much work has been put into this field, but it also has a lot of negative connotation for patients and for clinicians. And so our Canadian colleagues have really kind of taken a step further and been more advanced, quite frankly, than us in calling these heart function clinics. I think it allows us also to think about heart function along the continuum, as I was just alluding to, in terms of ejection fraction, in terms of age, in terms of symptoms, and in terms of response to therapies. Say that language matters when we talk about compliance or adherence. It's very common for us to see history of present illnesses like this one. A 47-year-old man is admitted with acute heart failure in the setting of medication non-adherence or non-compliance. But how nice would it be if we reframed that vernacular and used a 47-year-old man is admitted with acute heart failure. Potential barriers to adherence include cost and polypharmacy in the setting of recent job loss. Let us try and understand the circumstances of our patients and ask why they are not on medications as opposed to implying any kind of blame. And then finally, I would just make the argument, we're going to hear a lot about interventions today in heart failure, and there's a lot of exciting innovation in this space. But medical therapy gets a bad rap in this case because it's always considered medical therapy or a particular innovative therapy that involves an intervention or a surgical therapy. And I would argue that it's never or medical therapy. It is always and medical therapy. When we look at relative risk reduction by virtue of these individual pillars of medical therapy, we can see what a huge difference they make. With none of these on board, we have a 35% two-year mortality, which is along the lines of many cancers. With the addition of ARNI compared to an imputed placebo, there's a relative risk reduction of 28%, beta blockers 35%, aldosterone antagonists 30%, and SGLT2 inhibitors 17%. So with that, I leave you with some take-home points. Heart failure is a clinical syndrome. Pillars of medical therapy are imperative. Let us consider ejection fraction along a continuum when we consider medical therapy. Language matters. Let us talk about function. Let us consider barriers to adherence as opposed to non-compliance. And finally, medical therapy is never an or and always an and. Thank you so much for your attention.